All right. Well, we're a few minutes into our time together, and so I think we should go ahead and get started. Welcome, everybody, to our second webinar call for the CCO System Level Social Emotional Health Metric Pilot. My name is Elena Rivera. I'm with Children's Institute, and I'm here with my amazing partners in measured development. From OPIP, we have Colleen Royland, Lydia Chang, and Katie Unger. We also have some partners at the Oregon Health Authority's Health Analytics team who have really been supporting this work, as well as national consultant Sarah Samsell. So we're really excited to be here with you all and continuing this conversation and gathering your invaluable feedback on this work. For those of you who have just joined and haven't yet had a chance, please go ahead and edit your participant name to include the name of your CCO for our attendance recording purposes. That would be very helpful. Thank you. All right, I'll go ahead and kick us off. So here's our agenda for the call today. We'll be spending a quick moment just reviewing the kind of purpose and objectives of this pilot. We'll give some framing and an overview of the attestation measure. And we'll spend a few moments kind of rounding back on pilot webinar 1. So if you'll recall, back on February 25th, we all connected for our first pilot webinar to share about the social emotional health reach metric data. And we want to make sure that folks have a chance to provide any additional input now that they've had a little bit more time to review those data files and reports from the Oregon Health Authority. Then we'll spend the majority of our time together looking deeply at the attestation itself, and in particular components 1 and 2. So there are 4 total components, and we'll be diving deep onto the first 2 and really hearing your questions and feedback. And then we'll wrap up by looking at what we have coming up. So zooming out for a moment, we are here today working on piloting the CCO system level social emotional health metric, which is really focused on improving provision of social emotional health services for children from birth to 5 years old. And this metric was recommended as part of a measurement strategy targeted at supporting children's overall health and well-being and their kindergarten readiness. So back in 2018, we worked with a group of stakeholders on the health aspects of kindergarten readiness work group to propose a set of recommended metrics that could be CCO incentive measures and could catalyze health system behavior change, investments, and shared work on supporting kindergarten readiness. You'll see here that the first 2 of the recommended measures have been adopted and are current CCO incentive measures. And we're focusing our efforts now on development and refinement of this social emotional health measure. The objectives of this pilot opportunity are really to gather your invaluable input on the components of the social emotional health metric to ensure that they're clear, and to hear your input on the feasibility and anticipated impact of the work. We'll be assessing feasibility, reliability, and validity of the attestation data collection tools and our proposed scoring approach. And then we'll also, hopefully be supporting CCOs to gain familiarity with the metric and just build overall awareness and readiness for future implementation pending adoption of the measure. So here's our timeline of pilot activities. In February, we met together to review the social emotional health reach data. And I should mention that that webinar recording, if you were unable to join us, is now available online at the Oregon Health Authority webpage. We have a page dedicated to this work. I'll post the link in the chat in just a moment, but you can access the full webinar recording there if you're interested. Here we are today on our webinar number 2, reviewing the attestation overview and diving deep into components 1 and 2. Next up on March 31st, we'll have our third webinar where we'll be reviewing components 3 and 4 and gathering some overall feedback on the attestation. And then we'll have some pilot closeout activities. So we'll be sending out a survey to all CCOs. We'll also be hosting optional closeout calls with CCOs. And those activities are really to gather final feedback on the measure and scoring approach. And all of this work is leading us to April and May to the proposal of this measure to the Health Plan Quality Metrics Committee and Metrics and Scoring Committee for their consideration for hoped for adoption for the 2022 CCO incentive measure set. All right, we want to spend a few moments kind of framing this attestation. So the purpose of this measure is that children from birth to age 5 and their families have equitable access to services that support social emotional health and are the best match for their needs. We're hoping to really drive and support CCOs to address the complex system level factors that impact the services kids and their families receive, how they receive them, and for which there may be policy and payment barriers that need to be addressed. And we're also seeking to address a long-standing gap in the CCO incentive measure set, looking at young children in particular and behavioral health services in particular. So the activities you'll see as we dive into the attestation, the activities are really focused on building capacity within CCOs for enhancing services, supporting integration of services, and cross-sector collaboration in communities, and are also focused on using child-level data, so that reach metric data that we dove into last time together, to guide and inform efforts, as well as assess the sensitivity and specificity of the metric to these system-level activities. And we're really building a glide path to get from this system-level measure to a child-level measure. So our intention in year 1 is to launch this attestation, which includes 4 areas of work, 4 components, and to build on that work in years 2 and 3, continuing the attestation components and deepening the work across those 4 areas. And then in year 4, we are proposing that we would transition to a child level metric with accountability for improving provision of social emotional health services. So once again, the attestation activities are what we are proposing are linked to incentive payments in years 1 through 3. So a CCO would meet this metric by completing activities in the attestation. So improvements on that child level reach metric are not required in these first few years. However, you'll see that reviewing and using that child level data is a required component and embedded into the attestation. And then finally, we wanted to reiterate that these activities included in the attestation are really anchored to and informed by improvement pilots, which have been happening in various counties and communities across Oregon, and where we've seen that these activities galvanize improvements that have been detected in child level data. And the activities are also informed by extensive multi-year feedback from families, early learning and healthcare providers, and cross-system leaders. So all of these stakeholders have lifted up specific barriers and opportunities to improving the provision of social emotional health services. And we've been very careful and intentional to align our activities with those opportunities. So once more, there are 4 components to the attestation itself. Activities fall in these 4 buckets. So component 1 is the review and assessment of the social emotional health reach metric data. Component 2 is developing an asset map of existing social emotional health services and resources. Component 3 is CCO-led cross-sector community engagement. And component 4 is the development of an action plan to enhance social emotional health capacity. and today we'll be diving into components 1 and 2. Before we do that, we wanted to make sure to round back on the topic of our first webinar and hear any final input, questions, feedback that you all have on the REACH metric data that we reviewed.
Can you guys see the slides okay? We're trying to manage
they
that
look great.
task. Okay, great, thank you. All right, I'm Colleen Rowland from the Oregon Pediatric Improvement Partnership. And I was fortunate enough to lead the February webinar where we talked about component 1, which was related to you reviewing the draft data that was sent to you. And so we want to make sure that we round back on some of the questions that we had about that REACH metric and how it is calculated. So just to distill the feedback that we heard from the last webinar specific to the methodology of the REACH metric, we heard that you wanted more time to dig into the reports and identify questions and reactions to your team, because you had gotten that the Monday before the Thursday report. We had asked some questions about as a team, the intent of the measure was to be as inclusive of different services and outlined some pros and cons to being inclusive. And of the people that spoke on the webinar, there was general agreement that we should be as inclusive as possible and then allow CCOs to sort, particularly because the incentive metric is not tied to improvement on the REACH metric. And then there was some great feedback given about some of the opportunities that at a CCO level are to address policy, payment, and capacity, but also opportunities for the Inc. OHA, the OPIP, OHA, CI team to work with our OHA policymakers on some upstream issues related to coverage and kind of leveraging this opportunity that, given it's aligned with the governor's priority around behavioral health and young children, and if it were to become an CCO incentive metric, that could be some efforts that could be galvanized in terms of addressing the Uber policies. And that was relative to the conversation we had about the prioritized list. So we wanted to make sure that we gave time to really hear and listen again. And so we have some poll questions for you in order to help understand, as you've had more time to review those reports, what your feedback is on them. So we're going to be asking in a poll, a Zoom poll. I'm sure you all are pretty good at this by now, given we're on a year of Zoom life. We're going to be asking you these 4 questions. None of these 4 questions are new. If you've been listening to the TAG meeting since November, we presented 3 times to the TAG. These questions have all been in those TAG meetings too. So for the first one, though, we're going to ask the question of, you got that REACH metric at the end of February. Did you review the social emotional health REACH metric data that was provided to you? So it had 2 aggregate reports that were provided in different components, data by social complexity, and then a child level file. So Elena, do you want to unleash the poll?
Yes, I do. So this first poll is actually going to ask you all 4 of these questions together.
Okay, let me walk through it then. Apologies.
Sure.
So the first was, did you review the report that you got? I believe it was February 22nd. It's kind of sad if that date's memorized.
That's right. That's right.
That's sad. Okay, February 22nd, you got a report. Did you review it? The second is, do you have any questions about the data that was included in the report? And then the third and the fourth question, those questions are the ones that we have been asking. They have not changed in terms of some decision points we have about what to include in the REACH metric to inform and galvanize conversations. And so the first was, do we include claims that are with a diagnostic pairing currently below the line on the prioritized list? And in the conversation that we had at the last meeting, the pro of that is that it's anchored to what services children would benefit from and could help us look at that. The con of that is that CCOs are not required to cover that. They could. That could be some of your policy level improvements, but you're not required. And then the last question, question 4, is should we include claims that require provider taxonomy? And so you remember, in terms of the list, that would be claims in list 2 and claims in list 5. The pro of that is, in our goal to be as inclusive as possible, it would allow us to catch any type of claim that, if with those components, could count. The con of that is that's not a field that's consistently reported or included. Okay, unleash the poll.
Okay, now I will launch the poll. All right, a poll should have popped up on your screen. I'm waiting to see if we have any responses. There we go. Responses are rolling in.
And we would just ask that the people who complete the poll, obviously OPIP, the development team won't complete the poll, OHA won't complete the poll, but we really need the 11 CCOs that are part of the pilot to complete the poll. Looks like we have a couple people not part of CCO, so I just want to make sure the poll is representative of the 11 CCOs.
Responses are still coming in, so we'll give folks another minute. I'm seeing we have 13 responses. We'll give you 15 more seconds to get any final responses in, then we can take a peek at the results. I see your question, Peg. My guess is that we have multiple folks from some CCOs, so the same CCO may be submitting multiple responses, which is fine. And that's totally fine if you want to let your CCO colleague respond. All right, I'm going to end the poll and we can take a peek at the results. Okay. Now everyone should be able to see results and scroll up and down through them. Can you see them, Colleen?
I can, yeah.
Great.
So it looks like on question 1, did you review your CCO social emotional health reach metric? It looks like of the people participating that I hope were all CCO respondents, 79% said yes and 21% said no. If the barrier is you don't know where that was sent or you don't know how to access that in terms of who got that in your CCO, please put that in the chat so that we can help address that barrier, since that's a really important component about your participation. The second was, do you have any questions about the data? And it looks like on the flip side, 3 and 4 people do have questions about the data. So I want to go through and make sure that we poll questions on that. So we'll open it up in just a second. The third is, should we include claims of diagnostic pairings currently below the line in the reach metric? And of the people who answered the question, 57% said include and 43% said don't include. So that's helpful to just understand of the CCO pilot participants. That's something that we can kind of put into the hopper of thinking about that decision. And then the fourth is, should we include claims that require provider taxonomy in the reach metric? And 21% said include and 79% said did not include. So let's go to the 11 people that said, let's go to the 3 people opposite, the 3 people who have questions about the data. So if you have questions about the data that you want to ask right now, so 21% had a question, or 3 had a question. If you have a question about the data that you want to ask right now, feel free. Well, it's open, so you can unmute and ask a question. Or we're offering individual closeout calls with each of the 11 CCOs. So if you would rather ask that question in your closeout call, you can ask that in that question. Or option 3 is to write me, Colleen Ruland, in the chat and say, hey, Colleen, I want to follow up with you about a question I have about the data. So of those 3 people who still had questions about the reach metric, do any of those three want to ask their question now?
This is Jean from EOCCO. I said yes because Matt, our data manager, had a question. He and I met and reviewed our data, and so I may have just submitted it for him. I don't know if Matt, if you're on the line or not today, and I can't articulate his particular question. So because I don't think in his terms exactly.
I get it. How about this, Jean? I don't see a Matt. I've been looking to track the 11, and I don't think I remember a Matt Allcare. So what I will do, how about, Jean, we either have this be part of your round out call, or you can have Matt send a question and I can answer it. And then if we need to have a call, we can have a call. Does that sound good, Jean?
Yeah, sounds good.
Great. Happy to make sure we close that loop. Other folks? Okay. So I think this is really helpful. As you can imagine, we noted as a team on the 2 questions about whether to include or not include that there were great things. There were pros and there was cons, and there were pros and there were cons to each one. And so on the last call, everyone that commented said include. I think it's interesting and curious that on the polling, there's a different part. So we really appreciate you participating in the polling. I'm glad we have that. Does anybody want to share a little bit more about why you answered the way you did, knowing that we'll make this part of the closeout with CCOs in terms of the evaluation? But in terms of the first question, should we include claims in the REACH metric meant to just galvanize conversations in communities and inform asset mapping? Should we include claims that are valid and have diagnostic hearings that are below the line? So anybody who said do not include, since that is a little bit of a different shift from our last call. So there's 6 people that said do not include. Is there anything you really want us to hear and learn from you about why, as we're kind of putting this into the hopper, knowing that, again, the team, we could both defend both options, so we understand both sides. So of those 6 people, would anybody like us to hear a little bit more about your perspective? Either you can unmute and tell us, or you can put it into chat, or you can send us an email, whatever feels most safe and most easiest for you. Going once, going twice. Okay, and then Elena, can you pull up the poll one more time? For the other issue about provider taxonomy, is it up on yours and it's just not up on mine?
I think it is up on mine.
Okay.
But I can tell you the percentages. We had 3% say include claims that were, I'm sorry, 21% that say include claims, and 11 people, or 79%, who said don't include the claims that require provider taxonomy.
So does anybody on either side of that equation want to share why you feel that way, either in chat, in email, or in group conversation? Okay. Well, we'll make sure to provide an open-ended answer as part of the CCO pilot round out. And again, you have 2 options for giving feedback. Part 1 is to send us an email and put it into chat, or part 2 is part of the evaluation. Okay, I'm gonna move on so that we can make sure to keep on time. All right, so today we're gonna be talking about the attestation, which Elena mentioned. There are 4 components of the attestation that would guide CCOs to doing activities that align with the significance of feedback, that align with the improvement pilots that we've seen have been effective in moving forward improvement efforts, and that are aligned with the health aspects of kindergarten readiness work groups kind of guidance and vision. And so the 2 parts we're going to talk about today are kind of like how those parts work together. We're going to talk about the specific proposed questions in the attestation metric. Within each part, we're going to pause and ask you questions. So this polling is going to keep happening so that we can make sure we're kind of understanding what is clear, what is not. The feedback we'd really love from you, knowing that the elements in it are really informed by the last 3.5 years of work, are one, are you clear on what the question and the attestation metric is asking? And if you're not, what is unclear about that so we can make it more clear? Two is, as you're thinking through how you're going to answer it, is there any type of information in the attestation metric or any guidance we need to provide about how you might go about that? Knowing that obviously each CCO, the goal is actually to stimulate CCO level community-based conversations that are meant to facilitate this cross-sector conversation. Then the third is kind of understanding what information would be gathered if you have any questions about that gathering. And then, having you help reflect for us what systems or processes you would use to analyze, assess, and build capacity for services as is meant to be guided over time in this attestation metric. So the first component of the attestation metric, which you guys saw in the overview document that was sent by Elena on Monday, is really around, you get this data from OHA that provides aggregate reports of overall findings, aggregate reports of the findings by and for socially complex children, and then a child level data file that shows you the reach metric overall and by each one of those lists. So the purpose of attestation 1 is to incentivize you to use that data to look at that data. So the purpose of the 4 required elements of the attestation is around looking and using. And then the 5th one is giving you, a CCO, an opportunity to say, these are reliable, valid services that align with the construct that we're missing from your claims data. That is optional because, again, unlike your other person level metrics, that the incentive is tied to person level improvement, this metric is not tied to the reach metric improving. This metric is tied to you using the data to guide improvement efforts. So for the first year in particular, and currently as scoped, it is optional about whether you want to provide data to enhance that. That would obviously improve and inform improvements to the reach metric. So the first part of the attestation metric related to using the reach metric is whether you've reviewed the aggregate reports. So the question we just asked you. And so the aggregate reports are that group level report that is both over time and by children with social complexity. The second component of the attestation metric is whether you've reviewed the child level data file, because we recognize that that is a different piece of information that was provided for you. The third is that given you had this child level data, and given that the stakeholder feedback was significant, and given that the review committees that we are presenting this metric to, health and quality metrics and metrics and scoring, have explicitly asked us to ensure that this metric focuses on populations that have historical and equitable outcomes. Our next question is asking you about whether you've examined the child level data provided for at least one population that has an historical and equitable outcome. So we gave you examples that you as a CCO may use, but this is obviously an area where each CCO, you're going to build off your community level strengths. You're going to build off the social complexity data and where there may be opportunities. And you're going to build off the stakeholders that you're going to engage in component 3. That'll be a focus of the March 31st webinar. The fourth is then for the CCO to assess your payment and policies and your contracts relative to the claims and services. One of the big things that we heard from the health aspects of kindergarten readiness work group, from the stakeholders that completed the extensive surveys that fed to what we were using for this attestation metric, and from the improvement pilot, is that sometimes practices or providers experience that a service isn't covered or they weren't able to be reimbursed. And sometimes that is because of payment policies or contracts that maybe were confusing, maybe hadn't outlined components, perhaps there was a lack of clarity about some of the requirements. So this is really meant to address that given that the metric includes claims, given that we've outlined coverage on the prioritized list, given that it's meant to support the continuum of services that from an OHP coverage point of view, for those that are above the line, should be covered across sector, this allows you to kind of problem solve and think about whether there are barriers in terms of payments and policies, and whether there are opportunities to think creatively and with a transformation lens about how to achieve that goal, which again is a focus of that component 3 of the attestation metric, is that engagement of cross-sector stakeholders in that conversation about kind of what do the findings mean, what services aren't captured in the data, and how are there ways that we could capture that data, knowing that, again, per the recommendations of health time quality metrics and metrics and scoring, the goal is to transition to a person-level metric that actually captures the continuum of services. So those are the 4 required elements of the attestation metric that are really meant to, again, support you in using the data to just first review it, knowing that components 2, components 3, components 4 will all get us to this vision of an action plan about how we're going to improve access, improve focus on the social emotional services for children. So as I mentioned, 1.5 is an optional component of the attestation metric. So CCOs would not be required to do this, but we are allowing an optional component that if you get that person level metric, and in doing 1.2, 1.3, 1.4, you find that actually there are services being provided that are billable and meet the requirement, but perhaps you weren't capturing them in different situations. Perhaps you had an APM and the practices weren't submitting claims, but they could be. This could give you an opportunity to say, hey, from our end, this is the services that we're seeing, and to share learnings about how that metric, how that data could be captured better, and to be able to reflect on services not captured but could be billable. So that's why it is an optional one, because again, I know for your other child level metrics, you have a validation process that you can go through, because you probably really want to make sure that's 100% correct, because that's what the incentive metric is tied to. For this one, it is optional. Obviously, this is a novel metric. It has not been put out before, so we want to learn as much as we can learn in terms of an iterative process. So knowing I can't see the chat at the same time, are there any questions before we go to the next part?
There haven't been any questions in the chat.
Okay.
Wait, pause. Keisha, I see you raising your hand.
Thanks, Katie. I might be getting ahead of myself with this question. So are you gonna, I'm just curious on the attestation part, is it purely just like a yes, no, check the box? Is there like any kind of reporting or anything? Okay.
What you are seeing in these slides is what would be required. As an OHA OPIP Inc. team, we are thinking very critically about how to make this something that strikes the balance of meaningful, reliable, but also feasible. And so based on feedback from OHA, a number of the components are going to be yes, no components, because that is something that can be provided. There are a couple of questions that you're going to be filling out, like an asset map, and providing information that is the outcome of the work that you would do. So I think component 2 is probably the most intensive component of the attestation metric. The rest of the components are largely yes, no questions that you are attesting that you've done that work in that activity, or submitting reflections to that work or that activity. The last component is an action plan. And so that would be something that would be loaded. And on the March 31st conversation, we'll talk about that action plan, recognizing that we are trying to strike a balance of not requiring over documentation that misses the point of the work, but also needing to honor that health and quality metrics and metrics and scoring are going to ask some pretty pointed questions about how we know whether these activities lead to transformational activities, given incentive measures are tied to them.
Perfect. Thank you.
Sure. Okay, so given that component 1 is you got the data, attest that you've done that you reviewed that data. Because component 2 will be looking at what assets do you have in your community that may or may not be reflected in that data. Component 3 will be engaging the community on what the data says, what assets you have, and what are opportunities for improvement. And component 4 will be in developing an action plan. So starting with this first one, which is novel measures. This is a novel measure. It's never been done before. February 22nd, you got data that's never been shared in that way. We have some questions that we just want to make sure we understand relative to attestation component 1, that we're kind of leading folks to the right water in a way that honors the feedback and honors the kind of opportunities for transformational activities that we're hoping happen by virtue of this metric. So the first is, again, in doing pilot work over the last 2 years, we've engaged with a number of CCOs because we didn't want to develop a new measure, but we had not met a CCO that was measuring behavioral health services across the continuum, including screening and including services that are provided in integrated and specialty and early learning settings. So we just wanted to triple check of these 11 CCOs. And again, I'm going to ask only people who are from CCOs to answer this poll question. Does your CCO currently measure behavioral health access? And if you do, would you be willing, if you do, the yeses, I'm going to give you a heads up, we'll likely follow up with you because we're trying to make sure that this metric, we've reviewed it against any other metrics. And in the last webinar, we described for you what we pulled from and what we had to do new. The second is the purpose of the metric is to help you understand, according to billable services, that the CCO is accountable for this population and the CCO has the opportunity to cover these services, and the CCO has the opportunity to think about increasing capacity and increasing policy payment supports that would have these services enhanced. Does the REACH metric help you understand current access to the services that are in the REACH metric? The third is, we are assuming, and having worked with CCOs, you're going to have different processes in place for reviewing the aggregate reports, so those group level reports, versus the child level data. That's part of the reason we have it as 2 components in the attestation metric. It's also part of the reason that we provided the 2, because they can give you 2 types of information that could be used. So that's our third question. And then our fourth question is, relative to that optional component of 1.5, do you anticipate in the first year that you will want to provide additional data on social emotional services, billable social emotional services aligned with the REACH metric that you would want us to understand? The reason we're asking that is we are trying to think about a very CCO-centric timed approach to that. And because this metric in the first year is not tied to improvement on the REACH metric, we want to think about burden to you and processes given other metrics in the set are tied to that. So those are our 4 questions before we then open up to any additional questions. You want to unleash the
Okay,
poll,
I'm going to launch the poll.
Great.
And I'm seeing the first couple of responses trickle in. Thank you. We've got 8 responses. Give it another minute. We're at 9 responses. I'm waiting to see if we get a few more in. Okay, looks like we might have some shy CCOs. That's all right. We have 9 responses. I'm gonna, seeing that we've been at 9 for a little over a minute, I'm gonna end the poll and share results.
Great.
Okay.
Thank you, Elena. Okay, so in terms of internally measuring behavioral health, it sounds like 78% said yes. Great. So for those 7 people that said yes, I would love to hear and learn from you. I didn't see, I know there were 3 of you that had questions about the REACH metric data. I'm assuming you've been comparing and contrasting the social emotional REACH metric data with your own internal behavioral health access. Again, the social emotional REACH metric is really meant to capture both assessments, which include screenings, and services. So I'd be really curious to hear about whether your metric is narrowed to services and whether it's narrowed to services in certain sectors, given that the goal of the REACH metric is not meant to be narrowed. So either when we open up to discussion or when you have your CCO closeout, I'd love to learn what you learned when you compared the 2. In terms of understanding access to services for children, it looks like 1 person said not at all and 89% said somewhat. So I'm curious to learn a little bit more about that, given kind of what goes into the REACH metric and kind of the responses to that. So when we open up for discussion, I'd love for group sharing, or if you want to do it in the individual follow-up, that's fine too. We asked, will you have a different process for reviewing the aggregate reports versus the child level data? And it looks like 3 people said yes, 1 person said no, and 5 people said, I don't know. Understandable, you're starting off on that process, but that's helpful to kind of see that variation of the 9 people that responded. And then we asked the question of, do you anticipate submitting additional data on social emotional services your CCO provides for OHA validation? And it looks like of the 9 people that answered that, 2 said yes, 1 said no, and 6 said, I don't know. So one place we'd love to be able to get some input from you on is, as we're trying to think about feasible timelines and feasible processes for you as a CCO, how to think about that kind of validation process, given the validation is different for this metric than it is for ones that the funds are tied to. So thank you so much. It's really helpful to have those results. Elena, is it okay if we stop sharing so I can look at the screen?
Yes.
Okay. Does anybody want to share your qualitative feedback in terms of those questions? We can see the quantitative and we can see some of the follow-up. Does anybody want to share the qualitative feedback? And I can't see people's faces anymore. There we go. Anything anybody wants us to hear either in chat or in by unmuting?
Colleen, this is Tanvir.
Hello.
Yeah, so the number 3 question. Yeah, I did respond. I think I said no on that, but I wasn't very clear. Why would anyone separate those 2? So,
you know, in my experience, in the proof pilots that we've done, there's a set of work that you do in using the aggregate reports of using the aggregate data to support people looking at the aggregate data. Does this make sense? Does this not make sense? Going to community organizations and saying, this is what we found. So for example, in Central Oregon, we've done some work where we pull together early learning partners and practices around kind of looking at that aggregate report and kind of reviewing it together, which is a component of the Attestation Component 3. I've just found in CCOs that usually the people who, one, have access to the child level data file and the portal with OHA, and then who use the child level indicators are often in the measurement side of the CCO and often related to the components of measurement. And so I think there's opportunities within the child level to think, one, about how do you look at it relative to measures, but also how do you look at it relative to population health and thinking about it as population health indicators. And I know UHA, you guys are starting to think about the other component of the use of the child level data. So our experience has been that in general, the two different tools are very complementary, but sometimes the application and use and the people who review them are different.
Yes, now I'm getting a better idea, and I feel from the way you explained it, it'll help the CCOs because they have that aggregated data already, so we don't have to really do that work. Yeah, so
Yeah.
that's an added advantage. We can just take that and share with community partners to get, or rather sync our approach towards the delivery side of it. Yeah.
Yeah, thank you. I think your question helps me think about how we might word things in a way that makes that clear, which is part of I appreciate you asking the question because it helps me think through, I think, a little bit of a tweak we could do on that. Any other questions? I want to make sure we save time for component 2 because component 2 is a little bit, has a little bit more nuance to it. And I know we have 40 minutes, but any other questions, comments, feedback you want us to hear relative to your poll findings that we wouldn't be able to capture from your poll findings?
Colleen, this is Stuart from HealthShare. I was just going to comment regarding that first question on measuring behavioral health access.
Yeah.
And like most other people, that's definitely something we do, but I think maybe the framing is a little bit different than how it was posed in the documents that were distributed.
Right.
And so it's less about looking at capacity for each referral we might have each week and more about the timing to service. So it's kind of trying to get at the same thing, but it's not using the same frame that was used as a reference point.
And as part of your metric, Stuart, in some of the CCOs, we've been working with the REACH metric. There's been within specialty and their contracted specialty providers, how many people are going there. And then within some of their patient-centered primary care homes, looking at reach of the behavioral health providers. I'm curious, in the work you're doing around capacity and build, have these assessments, the component A, which was screening, and then services using these, because our services cut across the continuum in terms of integrated behavioral health, specialty behavioral health, and opportunities for early learning and community-based providers to submit claims. In the work you've done, have there been that combination already in place? And or are you saying, even within our components, there are new pieces to the puzzle that are in the new 0 to 5 social emotional health services metric?
To my knowledge, that hasn't taken place, but I'd have to tap in with our behavioral health providers a bit more. So I'm not sure I can actually address that directly.
Yeah.
Just a comment on that. I think when you look at the CCOs, much of this data is shared at the committee level.
Yeah.
In the CCO's operations, and they do not go to that granular level. But I feel like with this metric and the data that's been shared and the way our whole approach now with this social and emotional setting for children from 0 to 5, probably we'll have to go to that granular level and run new reports to inform our committees.
Yeah, and part of what the metric is meant to kind of focus on, which I hear you saying, Tanvir, is that transformational focus that when we talk about the continuum of social emotional services for children, and we think about wanting to kind of and focus a community level conversation about all children should be receiving screenings, which the claim is an assessment, and those can sit in a number of settings that normally are measured in one way. And then there are groups of children that would benefit from services that sit in a number of different settings. Part of the reason we wanted to create a metric that combined those parts that I hear you talking about is to combine that story. Partially because what we found is exactly what you're saying. There's people looking at like, okay, our behavioral health contracts, you know, we've given a global budget to the behavioral health providers, or we've accepted these parts. How many, we look overall, how many behavioral health services are provided. Rarely, I have not found a CCO, but I would love to hear if there is one today that has asked that question for birth to 5. So that in itself is something different, right? And then this is trying to kind of force this other conversation that you probably are looking within some of your PCPCH contracts, and you may be exploring early learning, but kind of thinking about for the measure forcing that cross-sector, cross-data component within your UM management, but thinking broadly within some of the other components of the services that are provided in that way. So I appreciate you noting that, because that is actually the intentional purpose of creating a cross-sector measure that way.
This is Jean. Colleen, I have a question about the cross-sector measure. We can only collect what comes through from the CCO in the claims. So how is this measure going to be collected through other providers who do screenings and other assessments that are in our region?
Yes. Can we go to component 2, and then
Sure.
Can we go to component next week 3 and 4, and then round back to your question at the end of the March 31st webinar, Jean, because there are parts of that are very intentional, and we're only on this very first baby part, and the majority of the attestation metric is actually 2, 3, and 4 that are meant to get at those other components and meant to incentivize some of the transformational opportunities and ways you could think about policy payment issues that could actually capture that. Again, recognizing that this is a CCO incentive metric that is meant to specifically focus on the 700 people's feedback that of the CCO incentive metric areas that we prioritize that the services and the cross-sector conversations that the services that a CCO could support. And so I think if we could come back on March 31st, Elena, can you make sure that we have Jean's question at the end of March 31st?
Absolutely.
I'm hoping it all ties together. And we've only had 2 parts on this one piece, so I want to get to the next part so we can honor how these all piece together. Thank you for asking it, and I want to make sure we get it. Okay, I'm going to move on just because I want to get to the next part of the attestation component. So, separate to the reach metric, we want the attestation metric to actually focus on, in your community, there are a number of assets that address the spectrum of social emotional services. They're going to help address the priority areas identified by stakeholders and that are meant to be the focus of this metric. So attestation 2 is really meant to guide you to seeing, identifying, and validating what those assets are in your community that can serve children, so that you can think not narrowly related to who are the people that build those claims, but separately thinking about, if we are taking a strength-based lens and thinking about what assets exist in our community that address social emotional services, what do they look like? And then what is their capacity? And when we think about the potential need for all children birth to 1 to have at least screenings or assessments, but the potential need that there's a component of children that are would benefit from reimbursable services. What is our strengths in the community? Who are the people that are there in our community who can provide those services? So that in component 3 and 4, you're thinking about how to connect children to those services, and you're thinking about ways to make those services accessible and those services sustainable in your action plan. So in terms of, again, trying to create a feasible, meaningful, relevant process over the 3 years and not requiring 100 things on the attestation metric in the first year, the way that we've rolled out looking at assets, knowing that each asset is equally important, but we needed to think about burden on a CCO. We have year one looking at the assets and strengths that fit within who you contract with for specialty behavioral health. Year two, and if you want to do year two and year one, you can do year two and year one. But again, just trying to create a staggered, feasible approach given the feedback we hear about measurement burden. Year two is honoring those patient-centered primary care homes who have attested in 3C3 on the standards that they have integrated behavioral health, understanding the services that their integrated behavioral health provide that are on that spectrum of social emotional services that are the focus of the metric. And then the third is recognizing that there is a critical and important workforce within early learning and other community-based social emotional health services that you would identify in the cross-sector engagement, which is in component 3 of the attestation metric, where we're going to talk about on March 31st. So that you can honor and recognize those services, understand their capacity, and start to think about in your action plan whether they could be part of the solution to increasing access for children, given that the premise of this measure is children are not getting the breadth and depth of a continuum of social emotional services. So that year 3 is intentionally not that year 3 is not important. It's meant that year 3 is actually informed by community engagement activities that happen in year 1 in component 3 of the metric. So if you have that sheet that Elena sent on Monday, that's the overview, that's how those tie. Again, as a team, we've been trying to think about feasibility in the first year, feasibility in the second year, and how these different components build off of each other. So the asset map is really meant to galvanize conversations. You have to talk to the different partners to understand what services they have. You will learn and talk to those partners about their strengths. You will learn and talk to those partners about barriers, and you will learn and talk to those partners about whether they have capacity to take on more children. We recognize that asset mapping can be an intensive process. So we have been able to pilot a template for asset mapping in a number of communities. And we are providing that template and the significant work in piloting that it took to develop that template over the last 2.5 years as a tool to guide the conversation. And again, that template just gets bigger. So year 1, at a minimum, it's required that it's the specialty behavioral health contracted providers. Year 2, it gets bigger to the integrated behavioral health and patient-centered primary care homes. And year 3 is based on what you learned those community providers. So in terms of the asset map, it would be a form, Keisha, that you would fill out that would have fields that would make it standardized across CCOs, but also guide you to not have to create a asset map from a blank page of paper. And so the asset map would help you identify what clinics serve children birth to 5, what counties those clinics are in. The reason we are looking at counties is, again, feedback from the 700 stakeholders that completed this survey and from the proof pilot is there are inequitable access by region. And so this is going to help illuminate whether you have access, if you're a CCO that is across a number of counties, whether there are potential opportunities in your action plan to consider how you might increase access in counties where maybe there are not services. The third is meant to look at capacity. So in doing the proof pilot work in a number of communities, we had found that a number of providers that exist actually don't have capacity to take on new referrals. So this is going to help you understand as a CCO of your assets that exist that are currently providing the services that are getting about 6% of children's services. And if the premise of this work is we want to increase access for children, an important factor in that conversation is going to be knowing whether the current providers have capacity. So this is going to help you as a CCO in your component 3, component 4 conversations to know whether this is something that needs to be part of your in-scope conversations for your action plan. Part 4 is understanding the diversity of the workforce. As we know, overall, a workforce that doesn't look like the person can sometimes be a limitation in people accessing services. And particularly when we're thinking about stigma of behavioral health, this can be a factor. And again, because health plan quality metrics and metrics and scoring have asked us to explicitly think about health equity, this is an opportunity to look and see, of your contracted providers, birth to 5, who would be focusing on dyadic-based therapies of the parent and the child, what is the racial demographic of those providers? Similar to the class measure that is currently in place, we also know that language and ability to speak language is also a component of access. And so this is giving you an opportunity to understand whether there's an opportunity or a barrier in access according to the language that those providers speak. And then the last one is a drop down of evidence-based dyadic therapy models offered. Again, feedback from the various stakeholders was that there is limited number of behavioral health services, and sometimes those services are specific to only certain modalities. And that can be a limiting factor in terms of thinking about how we ensure access to services. Because if you only have certain type of modalities, there may be certain populations that only go to those modalities. So in terms of those modalities, the drop down will be focused on a tool that we've developed over the last 3 years in partnership with the Oregon Health Authority Child Behavioral Health Team. It will be updated if additional modalities arrive. That kind of outlines the kinds of evidence-based modalities that would align with the types of billing and claims that you can submit for dyadic therapies. And then there will be an other option if you identify that other services are provided. So then the goal is to use those asset maps to then reflect on what the asset map is saying to you. So the purpose of the asset map is to then think about, if we from the reach metric know how many were accessed, and when we look about just one of our strengths, which is the specialty behavioral health, what are some of the barriers? Those rows in our proof pilots, those rows have been really illuminating in terms of potential areas that you could talk to your community about in component 3, and that you could put into component 4 in terms of your action plan. In year 2, it goes broader to think about the strengths and the asset that you have in patient-centered medical homes who attest that they have integrated behavioral health. And again, similar to the specialty behavioral health, we will provide you a template that has been developed and piloted in proof pilots around, like, how would you understand the strengths and assets in the integrated behavioral health? So again, what is their capacity? What's their race, ethnicity, languages spoken? Here it's broader because, again, integrated behavioral health can be an asset for you of either doing assessments, so screening. So the clinic could be doing screenings, or the integrated behavioral health could be doing screenings or assessment. Integrated behavioral health can also be an asset to you in doing brief interventions that are included in the REACH metric, and brief interventions that maybe they do, but they don't bill, in terms of understanding the strength of that resource. And then there are some clinics, I would say in OPIP's work with a number of clinics across the state, I don't think it's a majority, but there are some clinics who have trained integrated behavioral health staff who are able to provide dyadic therapies and do. So this is helping you identify what are the strengths in those integrated behavioral health that you can put on the map as like an opportunity to think about how do we increase access to the continuum of services. And also, what are those barriers to those providers providing those services? So within the assessments and screening tools, again, there's a claim called 96127 that is in the REACH metric, but the dropdown will allow you to understand what kinds of screenings and assessments are happening. It will also guide you to explaining what kinds of screenings and assessments capture and are specific to social emotional health. And then in the dropdown, we'll outline specific interventions, some of them not tied to diagnosis because they are brief interventions that are meant to assess the family, get them engaged. Some of them tied to diagnosis because they are interventions about those diagnoses, which include at-risk diagnoses. And so we've labeled them according to the claims that are in the REACH metric, but also encourage you to find out what other types of brief interventions are being done to inform this conversation about the strengths that exist in this node in your community. And again, that third one for those PCPCHs who do have integrated behavioral health, who can provide dyadic therapies, one, it's going to be helpful for you to see how many have that. And then two, it's going to be helpful for you to see whether that is a strength in the community, or are there opportunities to think about leveraging those existing staff to be able to bridge the gap of capacity in terms of providers. So again, with this asset map, you'll be able to say, of all the PCPCHs that serve children that we contract with, how many did attest to 3C3 of having integrated behavioral health? That in itself would be interesting to look at. The second part is you'll actually be able to find out, of those that did attest, how many do those providers that they attested are there actually see young children? And how, of those that see young children, what are the breadth and depth of services that they have? And where might there be opportunities there, again, that you could talk about in component 3 and component 4. So the last year, again, not because it's not important, but because it's informed by the year component 3 and component 4 activities in years 1 and 2, are understanding the assets that exist in early learning and other community-based settings. Our state and a number of your early learning partners are really focused on enhancing social emotional services. And there are some strengths and some connections there that we're hoping that this transformative system level metric hopes to support. So year 3 would be focused on those providers that you identified in component 3 of the metric in year 1. On the next page, I have a draft list of, in the improvement pilots, the kinds of people we've identified that are trained in providing continuum of social emotional services. That could be a workforce that you have, it's just not a workforce that's contracted with the CCO yet, or a workforce that we figured out how to increase access for yet. And that may be some of your strategy, question mark, in your action plan. I will note a number of the rows that are in the potential template in this process is actually meant to align with some of the priorities in Raise Up Oregon and in the CCO requirements that you have to engage with your early learning partners. And again, as I think Jean so well articulated on the last call and Susan so well articulated on the last call, if we're really going to address increased access on the continuum of social emotional services, we're going to need to address family, community, stigma, and these partners are critical partners in addressing that. And so this component of the work is actually meant to support that, and it's meant to support those conversations that then would get informed in terms of component 3 and component 4. And as we noted, we included claims that could be reimbursable by these early learning providers. You may not be reimbursing them, or those providers may not be Medicaid contracted providers, but that may be something you choose to do because those people have the skill set and they've been trained on that. And that is a creative opportunity that you may choose in your region to address the gaps in capacity of services and the gaps of available providers, which again, we noted was one of the most resounding, overarching shared barriers that was noted across the stakeholders. So again, currently in year 3, and again, this will be very tailored to your community context, and this will be very tailored to what you find in component 3. Examples of the kinds of services that may exist in your community that should be seen as a strength. Examples from our past work, but not limited to these examples, are home visiting providers with infant and early childhood mental health training, early Head Start providers with infant early childhood mental health training, some early intervention, early childhood special education staff for those kids who are eligible for EI have hired and created skill sets around social emotional health. There may be evidence-based, evidence-informed parenting classes with the focus on attachment and social emotional health. We know a number of regions that have leaned into evidence-based parenting classes that focus very specifically on attachment and some of the components that are deeply related to social emotional delays. Family relief nurseries in your community may have specific infant and early childhood mental health training. And again, in component 3, I'm looking forward to hearing all the different community stakeholders that you might identify in the creative solutions. That's the purpose of this system level metric, is to support that transformative thinking. And so some of the questions we'll be asking is, if that's a strength and that's a person who has the skill set that could be billable or reimbursable, is that an opportunity to think about creative thinking? Is there a way to increase education and pathways to these services? And could that be part of your action plan? If we know that there is places where there's a great service, but due to its funding or due to its availability has limited capacity, is that something that could be a focus of like, well, if it's a muscle or a great strength we have, how do we increase that capacity? So that is component 2. It's looking at the assets in your community, staggered over time to make it feasible, looking across those different sectors and those different strengths. So our 4 questions are, given that one of the really important pieces of feedback we got from the stakeholder survey and from the improvement pilots was the people that exist now are at capacity. Majority of them can't take on more referrals. That is why that is an intentional component of the asset mapping. Because for you as a CCO, you would know who you have contracts with. I don't know how you would know who you have contracts with that actually are at capacity. They can't take new referrals. So this work, this incentivized transformational metric is meant to support that work to help illuminate that issue. So we put into the asset map how we looked at capacity in our proof pilots, but I would love to learn how you guys look at capacity of services and if there's a way to refine that row in the asset mapping. The second is, I know that Oregon Health Authority provides you information about which clinics have attested to certain standards. And so we are really curious about whether you currently use that now. We know some CCOs use that in order to provide PMPMs for behavioral health, but we're just curious about, is there any learnings around that that you want us to hear, or any thoughts you have about, you think that, if we're proposing that that be used as kind of a tool that you then use to understand how you can engage with those PCPCHs, is there anything you've learned around that that you want us to make sure we take into consideration as we're aiming for this feasible, meaningful, reliable, and valid process? And then the third is the templates provided in here are really built off hard work and frankly intellectual property that took about 3 years to develop and has been really a key component of helping guide communities to, when we're talking about kind of breadth and depth of social emotional services, and we specifically talk about what are dyadic therapies for children, what do we actually mean? And so again, we just wanted to get a sense from you, knowing you just saw this, so we'll probably have to do this repeating polling again like we did for component 1. Do they provide you with something that's meaningful and feasible to complete? Is there any feedback you'd like to give us, knowing that that was our goal, was to try to create something that wasn't a blank page, but also trying to create something that was also informative by virtue of completing it. And then lastly, any other considerations? Door open in terms of giving feedback on this second component of the 4 components of the metric.
Okay, I'm going to launch the poll. We've got 7 responses. We'll give it another minute. Okay, we're hovering at 9 responses. I'm wondering if 9 is just the number of CCOs that we currently have on, which is okay. So that we can start our discussion, I'm going to go ahead and close the poll. If you haven't had a chance to respond and you still want to submit a response, please feel free to send us a message in the chat. But I will end the poll now and then share results.
Okay, sorry, I'm answering a question in the chat. That's to me. Hold on.
Sure, no problem.
Okay, I know we have 12 minutes. Okay, poll. Oh, shucks, I lost the poll.
Oh no, let me see.
Do you want to read it? It's probably,
yeah, absolutely.
When in doubt, it's Colleen's technical ability.
No
so go ahead
problem.
and read it for me, Elena.
Yeah, so the first question on standards or best practices for defining capacity for behavioral health. 3 respondents said yes, they do currently have or use a way to define behavioral health capacity. 1 said no, and then 5 said I don't know.
Great. For the 3, is anybody willing to share how you define that, and if the way you define that is different than in the asset map, so that would be a concern? This is a place really where we want to, because there's no like absolute standard, we really want to think about this and understand this relative to current work. And if you don't feel comfortable sharing on the call with other CCOs, if you could either chat one of the OPIP CI teams now or send us an email. I really want to hear from those 3 to make sure that we're hearing when in the proof pilots, when we did the capacity and looked at the literature on how you define capacity for behavioral health, we used certain strategies. But again, this is an area and piloted those strategies as something helpful, but this is an area where I really want to make sure we're aligning with and hearing from CCOs about ways you do this, because we're deeply committed to something that is feasible and meaningful.
Absolutely.
Actually, this is Jean. I put yes, but now that I think of it, we are in the process of redefining because we are struggling with that.
Okay, so it's an area where it's like kind of hard to come up with.
Well, the lack of, yeah. Mm-hmm. So yeah.
Got it. Okay.
About that.
I'm putting this on your one-on-one closeout, Jean, so I can hear why you're struggling, what we can learn from it, and how to move forward. Sorry that you have to be the guinea pig on so many issues so that we can learn.
Thank you for sharing, Jean. Others, please do feel free to share in the chat or via a message. I'm going to read the responses to question 2. Yeah. So, are you currently using information provided by the OHA PCPCH program to identify clinics with integrated behavioral health? 7 folks said yes, and 2 said no.
Okay. So for those 2, if it's that you don't know that exists, or you don't know how to do that, and it may not be, but if it's that you don't know that you could do that and that you don't know that you have that information, could you reach out to the OPIP OHA Inc. team or I keep doing that. I'm sorry. Today's been a day of other meetings. The OPIP OHA CI team, and let us know so that we can bridge that information gap for you and connect dots for you. I want to make sure that it may just be you don't do it because it's not part of your processes, but if it's a lack of information, I really want to make sure we connect in on that. Third question, Elena.
All right, so do the templates and resources support you to meaningfully and feasibly complete the asset mapping activities? 0 people said not at all, 6 said somewhat, and 3 said yes.
Okay. Of the 6 who said somewhat, is there anything we could do to improve the forms and improve the processes that would make it more feasible and meaningful, reliable of what we're trying to do? That is our goal. Any comments or feedback you want to give us today, knowing, of course, your door is always open to give us feedback on a non-public call. Okay, last question, Elena.
Oh, that was it. Those were the 3 polling questions. This last one's just an open discussion question.
Any feedback on component 2 that isn't reflected in the questions that you want us to hear today? I love the chat, by the way. Thank you. There's parts of that that are helpful to us as a team.
Yeah, thank you for sharing, Rebecca. We absolutely understand needing to kind of sit with these tools and templates a bit more to think about what your response would be to that 3rd question.
Especially on a rainy day. I don't know. I feel like I'm slower in digesting a lot of detail than I was yesterday when it was sunny. Okay, well then let's tell you what's going next. Can you see the looking ahead slide, Elena?
Yes.
Okay, great. All right. So looking ahead, we have our last webinar that is on the last 2 components of the attestation metric. So again, on Monday, you got the overview document that described component 1, we talked about today. Component 2, we talked about today. March 31st, we'll talk about component 3 and component 4. Elena, do you want to give like a razzmatazz about what's in 3 and 4 quick?
Yeah, absolutely. So component 3 is really focused on cross-sector community engagement and thinking about both the breadth of community partners, including families who your CCO could be engaging with on the data, on the asset mapping, and on the identification of strategies and priorities for improving access to social emotional health services in your region. And in addition to the breadth of services, we're also going to be asking questions for you to attest to that really speak to the depth of engagement, the strategies of engagement that you're using, and the ways in which you're engaging and centering voices of those who are most impacted by these services, with a specific focus on children and families who have been historically marginalized. So that's the focus of component 3, that community engagement. And then component 4 is an action plan. So the development of an action plan that addresses key target areas and has and outlines a strategy for making improvements toward building greater provision of social emotional health services. So that's what we'll be diving into on the 31st. We'll also hear any input on just overall scoring considerations for the attestation and just gathering any feedback on perceptions of just across the board for this measure, acceptability, feasibility, usability. And what we hope to be doing too as a development team is listening, hearing, and thinking through any outstanding questions and areas of input for our pilot closeout survey and these optional calls that we've been referencing. So knowing that the end of this pilot is around the corner, we want to go ahead and put the offer out there that if your CCO would like to schedule an optional closeout call with the development team to surface or talk through any pieces of feedback, any remaining questions you have about this work, please go ahead and reach out to me so that we can start scheduling. I know that calendars can be quite busy to coordinate, especially if you want to involve multiple folks from your CCO. So please go ahead and let's get that ball rolling so that we can schedule those for April.
All right. Well, thank you so much for your participation. You made it to 4:30 on, I think it's Thursday. One more webinar remaining unless you request the closeout. And as always, if you have any questions, areas of input that you want to provide, we really, really appreciate it. But thank you for your time today.
Thanks so much, everyone. Have a great rest of your day.